So welcome to this wonderful sunny day. We're going to be spending the next hour talking about Credo Therapies, which is a digital program-led psychological treatment for binge eating. So if you're expecting something else, you're in the wrong meeting. I'm Becca Randall. I'm the mental health lead for Health Innovation Kent, Surrey and Sussex, and I'll be taking us through the next hour with some fantastic colleagues. If we could go to the next slide, please. So a bit of housekeeping. It's going to be recorded. We'll circulate the slides and the recording after the event so you can share with colleagues. Please ensure your mic is off and your video is off. And we won't be taking questions because we're only here for an hour, but we will take we will verbally, but we will be taking questions through the chat. We'll try and answer those. Those that we can't answer, we'll share after the event with the slides. So please do use the chat function. And we'll share, as I said, we'll share afterwards. Next slide, please. So an introduction to today. This is a really exciting piece of work that's been funded by NHS England and the Health Innovation Network, Wessex and Kent, Surrey and Sussex. And we've been, through the Office of Life Science and NHS England, we've been working for nearly a year now with Credo Therapies, an exciting innovation in binge eating, and our trusts where we've been able to deliver a real world evaluation in Kent and Medway and Dorset. We'll be hearing from the trusts and we'll be hearing from Credo Therapies about the product and the innovation itself. And we'll be hearing from our wonderful colleagues from Health Innovation Wessex around the evaluation, what the evaluation told us in a real world setting. And then finally, we'll be pulling the webinar to a close and be able to tell you about the next steps. Okay, without further ado, I'm going to pass over to the next slide and introduce colleagues Nick and Lisa from Credo Therapies. Over to you guys.
Hello, good morning, everyone. Thank you so much for joining us today. My name is Nick Mercadante. I am the CEO of Credo Therapies. I'm also joined here by Dr. Lisa Debrew, who is our Chief Clinical Officer. And today, as already discussed, we're addressing what I think is what I know is a growing challenge in the UK and really worldwide, which is binge eating disorder. It's the most common eating disorder in the UK. It affects, depending on the data you look at, between 2 to 4% of the population during their lifetimes. Many also go undiagnosed, and certainly fewer than half of those who are affected ever receive any sort of treatment. And I think some of the most pressing concerns from my perspective and from Credo Therapies' perspective come down to that the waiting lists are very long, right? It's challenging to treat all who need care. We don't have enough resources in NHS in terms of treatment and providers to reach everybody. Stigma remains very high. It's hard for people to reach out for care. And then in general, once somebody does, access to specialist care becomes limited and usually gets reserved most often for those who are most highly acute and in greatest need. So I think the trickle-down effect is that, and this is what concerns me, is that oftentimes coupled with people going undiagnosed, we also fail to get to preventative or mild to moderate care. So I think that that's where the NHS needs extra help and where Credo Therapies comes in, is trying to get to the root issues before they've progressed, and then also trying to take some of the healthcare infrastructure burden off of the NHS trusts and the providers who are trying to do their best work under challenging circumstances. So Credo Therapies delivers digital CBTE. Dr. Debrew is going to talk more to you about that program, but from a high level, the program is a self-guided treatment predominantly through an app, and it has the ability to also provide timely human support along the way. The model is designed to reduce barriers to entry for most patients and make it much easier to deliver evidence-supported treatment in a variety of different settings, and also with or without more intensive provider intervention. So without further ado, I want to hand things over to Dr. Debrew, our Chief Clinical Officer, who's going to share more in-depth insight into the digital CBTE program.
Thanks so much, Nick. And could we just go back to the first slide for Credo Therapies? I'm delighted to be here today. I'm Dr. Lisa DeBrew. I'm a clinical psychologist and the Chief Clinical Officer, Credo Therapies. And it's a great opportunity for us to speak and hear from the NHS Trust about their experience and from the health innovation teams as well. So I'm going to spend a few minutes talking to you about digital CBTE to give you hopefully some insights into what the programme is and our aims with it as well. It was originally developed by Credo, who are the Centre for Research on Eating Disorders at Oxford, and it has built-in expertise from CBTE, which is a therapist-led treatment for eating disorders. Credo Therapies was formed in 2022, and our aim is really to deliver and develop digital CBTE. We have a screenshot of what the initial programme looks like as a registration page on a phone. And our aim really as Credo Therapies is to be of social impact. Next slide, please. So we have both a challenge and an opportunity, which Nick introduced. Next slide, please. So the challenge is that eating disorders impact a significant number of people in the UK. We have an estimate from Beat of 1.25 million people in the UK with an eating disorder. And when we think about eating disorders characterised by binge eating, and we apply a 3% prevalence rate to the population of London, that's around 270,000 people who may possibly be living with binge eating disorder. As Nick mentioned, some individuals may be reluctant to seek help due to feelings of stigma or not knowing where or how to access the right support. We have evidence-based treatments, such as those in the NICE guideline, NG69. And in the NICE guideline, the term CBT-ED is used to refer to individual eating disorder focused cognitive behavioural programmes. So what we describe here as the treatment gap is there may be a number of people experiencing eating disorders characterised by binge eating who are undetected and therefore untreated within the community. And digital programme-led treatments may help to close this gap, where the interventions are delivered by the programme themselves, and that's what we're describing here as being programme-led. Next slide, please. So as Becca mentioned, digital CBTE is a digital programme-led psychological treatment for binge eating. And on the next slide, I'm going to take you through what the programme is and then how people can use it. Next slide, please. Digital CBT is a digital translation of a printed programme which currently exists called Overcoming Binge Eating, and it identifies the maintaining mechanisms using strategies from both CBTE and the printed programme. So it's currently a Class 1 medical device in the UK. It can be used on a mobile device like a smartphone or a tablet, but it can also be used as a website on a computer. It takes between 8 and 12 weeks to complete, depending on the pace that the individual works through the programme at. And it's intended to be used by people with binge eating disorder and bulimia nervosa, currently over the age of 18. So we do have standardised questionnaires, such as the PHQ-9, the EDQ and the CIA, currently built into the programme to assess mood, features of eating disorders and secondary and clinical impairment throughout different time points within the programme. Digital CBT has been developed with involvement of people who have lived experience of eating disorders, and the programme is adapted through iterative cycles of development to make sure that it meets the needs of people who it's intended to be used by. Next slide, please. So this is a screenshot of what digital CBT, the programme, looks like on a smartphone. And this is one of the main screens that somebody might see on there. You'll see at the top, there's a number 1, and that's referring to a session number. So people can move through the sessions from this main screen. There's also a calendar feature which people can use to support self-monitoring. There are additional resources and content, including actionable to-do lists, and people also get feedback on their progress, which you'll see in that progress report feature there is linked to information they're provided to individually. Next slide, please. So in terms of the programme, there are 12 sessions. Each step consists of a series of those sessions, and in total there are 12 across the whole programme. Digital CBT is progressive, and it takes a scaffolding approach where each session builds on what was accomplished in the previous one. That means that you can't complete the programme in one go, and that sessions need to be completed by the individual in a set order, and we make those sessions available to people one by one. Next slide, please. So we've talked about the sessions, and those sessions are divided into 3 core steps within the programme, and those steps should be completed ideally over 8 weeks. The goal of the first step is to help individuals regain control over their eating, and the second step is really concerned with mastering triggers of binges, and the third step is remaining on staying well in the long term. So it's really important that people complete all those steps in a certain order, including that final step as well. Next slide. So if we think about the programme and what it includes, there are different ways that people can use it. So the programme is designed to be used by individuals independently, and we're calling that self-guided, where somebody completes it on their own, at their own pace and in their own space. And for that reason, it may be suitable as a waiting list intervention where somebody can use it in a way that works for them, but still within the parameters of the steps and sessions that I mentioned earlier. It can also be used as a guided intervention. So it's suitable for use with a coach or a guide in what we describe as guided self-help. So we do have a accompanying clinician dashboard, which is linked to digital CBT for that exact reason, that a coach or a guide or a clinician is able to see the progress of somebody using digital CBT. And the aim is really that the programme is followed by the individual, that they're in the driving seat. So the coach or guide or clinician is not leading them through it, but really supporting them and being alongside them while they go through the programme. Next slide, please. So hopefully that's given you some insight into the programme, how it can be used within a care pathway, and some of the history behind how it was developed. So now we're going to hear from the 2 NHS trusts where digital CBT has been piloted, both in that self-guided medium and also as a guided intervention. And we're also going to hear from the Health Innovation team, who has evaluated both pilots that the NHS Trust delivered in.
Thank you so much, Lisa and Nick. I must say it's been a delight working with you both over the past year or so. So thank you for that. I've put your details in the chat, Lisa, so people can contact you directly. And if there are any questions that you can answer while the presentations are running, that would be fabulous. Thank you, guys. So we move on now to hear about the evaluation of the real world in the real world settings. It's my pleasure to introduce some wonderful colleagues, Emily and Amanda from Health Innovation Wessex. Thanks, guys.
Good morning, everyone. It's wonderful to have the opportunity to share some of the findings from our real-world evaluations. My name's Emily. I'm the Associate Director for the Insight team here at Health Innovation Wessex. So we're also part of the Health Innovation Network. And I'm joined by Amanda, who's one of our evaluation programme managers and led both of the real-world evaluations. Next slide, please. I will briefly introduce our team. So the Insight team, we're a team of evaluators. We're mixed methodologists. Our team was established about 9 years ago now, and very exciting. We've just completed our 100th evaluation this year, and we have particular expertise in the real world evaluation of digital technology. So it was just fantastic that we were able to deliver these real world evaluations, and as Becca mentioned, supported by our commissions from NHS England and the Office for Life Sciences. Next slide, please. We thought it would be helpful just to understand a little bit of the chronology and how the opportunity for these real-world evaluations came about. So there was a roadshow, the Southeast Innovation in Eating Disorders Roadshow, and Credo Therapies digital CBTE was one of the innovations that was showcased at this event. From there, 2 pilot sites were identified, Dorset and Kenton Medway. They have different use cases, as Lisa's explained, of digital CBTE. And just to say up front that we didn't undertake a comparison of the use, that these were 2 standalone real-world evaluations. And as part of this, was identified that this was an opportunity to generate some evidence in a real-world setting. And we go through a process of co-design. In this sort of orange bucket at the bottom, these are our enablers and facilitators that really supported us at Wessex to undertake these evaluations. So we had the engagement, support, project management, expertise, and insights from our health innovation, Sussex colleagues, our innovator, Credo Therapies, the academics at Credo, the fantastically engaged clinical teams at both sites, all supporting a co-design process to ensure that the evaluation framework was going to be fit for purpose and to answer those questions and enable those decisions at the end of the process. Next slide, please. Just very briefly, because we've got colleagues from both these sites on today who will give you more information about the use of digital CBT in their particular setting. It was, for each site, it was very much to fit with the pathway that they had in place. So for Dorset, use as a pure self-help intervention for patients on the waiting list. Next slide, please. And in Kenton Medway, this is where digital CBT was used alongside supported sessions with a mental health and wellbeing practitioner. It was fantastic that Wessex was brought online as the evaluator at the outset of both of these pilots. So we could be there for the whole journey from start to finish and really get to know the teams, both within the innovator and in the clinical setting really well, and their support for the RWEs. I will just move on to the next slide, please. So through a process of co-design, we did settle on an approach that was equal across both sites. And for both evaluations, we were aiming to understand the experiences of patients and the staff and how the use of digital CBTE impacted on patients' clinical outcomes. The Wessex team undertook analysis of the standardised self-reported measures, and these were the measures that patients were recording within the digital CBT programme, both before and then after the intervention. And our qualitative methods were some semi-structured interviews with patients. We undertook a qualitative staff survey, and we were able to interview some supporters at the Kenton Medway site. So that is a very brief overview of our approach. Once I've stopped talking and handed to Amanda, I'm going to drop links in the chat to where you can download the full report. So Amanda, I will now hand to you, please.
Next slide, please. Thanks, Emily. Hi, everyone. So I will start off by highlighting some main findings from the Dorset pilot. And as Emily's explained, in Dorset, digital CBT was used as a self-guided intervention for people on the waiting list to be seen by the service. So on the left-hand side of the slide, the table shows the flow of patients through the pilot. And I'll give some context to the numbers there. if somebody was interested in completing the digital CBT program, they registered and created an account, and they were then asked to fill in a screening questionnaire. And the screening questionnaire was designed to check that the digital CBT intervention was a good fit for them and their eating disorder, and that was based on criteria defined by the service. So that being the case, that digital CBT was suitable for the person, they then went on to provide their consent in the programme, and it was at that point that they were asked to fill in the self-reported measures that Emily and Lisa have alluded to. They then went on to work their way through the programme, and at the end of the sessions, they were then asked to complete the same questionnaires again, so that would enable us to make that pre and post comparison about how they were doing clinically after the use of digital CBTE. And in the Dorset pilot, the number of people who completed all of those steps was 14. So our evaluation cohort for Dorset was made up of 14 people. In terms of the measures that people were asked to complete within the programme, these were all really gold standard measures that are widely used for assessing different aspects related to eating disorders. So that included the Eating Disorder Examination Questionnaire, the EDEQ6, which asks about the frequency of episodes of behaviours related to binge eating within the previous 28 days. And in particular, question 14 of that questionnaire asks about people experiencing a sense of loss of control over their eating, so which is obviously related to binge eating. They also completed the Clinical Impairment Assessment Questionnaire, which is designed to assess to what extent an eating disorder is having an effect on somebody's wider social functioning, as well as the Patient Health Questionnaire 9, which looks for the presence and severity of depression symptoms. So looking then at the chart on the right hand side of the slide, what we can see there are the two bars which represent the pre and post scores for patients or people once they'd completed around the digital CBTE, and in each case a lower score denotes an improvement for patients. So what we can see there is that this slide shows evidence of a really beneficial effect for people of having undertaken the digital CBT in its self-help form. And across those 4 measures that are shown there, each of those improvements were at the statistically significant level, so they were really encouraging quantitative findings. Next slide, please. So in terms of the qualitative findings for the Dorset service, we identified through thematic analysis a number of themes related to the perceived benefits and some challenges of the programme, using the programme. So as you can see there, people appreciated the digital CBTE as being a really nice thing to be able to work through and also to offer from the perspective of staff to people on a waiting list. The format was seen as accessible and easy to use, and the content of the information provided was really appreciated, especially the information around the importance of regular eating and kind of getting a consistent pattern of eating. Positive effects on eating behaviours were reported, and that was primarily around people feeling that it did enable them to get into a better routine and to eat more consistently, and as well as being able to get back on track more quickly if they did have an episode of binge eating. In terms of challenges, there were a couple of challenges mentioned around the challenges of working with a solely automated program. So that really related to the fact that sometimes people could feel that they had a query that they would have liked some help with. They weren't quite sure if they were filling it in, filling the program in right, but they didn't. There wasn't really in the form used in the pilot. There wasn't as yet the opportunity for any two-way communication. So that was a suggestion really that came out of this for the incorporation of some two-way communication mechanisms, and ideally they would have liked some human touch points as well. There was some reflection around the placement of digital CBT in the recovery journey. So that was around the fact that for some people this was seen to be likely to be sufficient in terms of a treatment in and of itself, meaning that some people may then not need to go on and be seen in the service. Also the recognition that for other people it would almost be like a springboard, a good foundation for the treatment that they would then go on to have, as well as the acknowledgement that it wouldn't be suitable for everybody, so it wouldn't hold a place in everybody's recovery journey. Next slide, please. Thank you. So on this slide, there's a few quotes there that illustrate the themes from the perspective of staff and people using the programme. So I'll just leave it just a couple of moments for you to have a chance to read through those. I hope that gives you a sense of what people were saying to us about it. Next slide, please. Okay, so moving on now to the Kent pilot. So again, on the left, we've got the patient flow through the pilot. In Kent, just to mention, as Emily said, that the digital CBT was offered slightly differently. So it was offered in Kent as guided self-help. So people were given the program to work through, but they were also offered a series of supporter sessions to support them through that process. So exactly the same steps there in terms of screening questionnaire and filling in the questionnaires pre and post. And in Kent, our cohort size was 16 people. So again, on the right hand side there, we see the pre and post scores against the same four measures as in Dorset, and similarly to Dorset, this shows a positive impact for patients of having used the supported digital CBTE program. And in each of these cases, the results, the change, the improvement was at a statistically significant level, as well as being at a clinically significant level. So you can see in 3 boxes there that the post scores have gone below a clinical cutoff marker, which again is really, really encouraging. Next slide, please. So in terms of the themes that arose from the pilot in Kent and Medway, again, they related to benefits and perceived challenges. The digital CBT supported offer was seen as a really quick and easy way to access help, which was very appreciated. There was a couple of themes that related specifically to the supporter sessions. So these were seen and appreciated as offering an opportunity to talk things through, express any concerns, maybe have these reframed and then enable people to feel more positive about their ability to make a change. The supporter sessions were also seen by staff as a way to encourage people to stick with the programme, to stop them giving up if it was feeling a bit tough, and to make sure that they were getting the most out of it. Behaviour change was also reported, including a reduction in binge eating episodes, and staff also reported that they found it a useful tool to help them prepare for working with patients, and they felt that it was developing their own skills as well. And in terms of challenges, there was initial scepticism expressed about the digital offer. People admitted that they felt a bit put off by that at first, but then explained that they quickly overcame those concerns as they started to work through the programme and work with their supporters. And again in Kent, it was acknowledged that this wouldn't be an intervention that was suitable for everybody. particularly people with comorbidities may struggle. It was felt that they may struggle to engage with this. Next slide, please. So a few more quotes there about staff and patient views of the supported programme. Next slide, please. And just to sum up then, the evaluation findings from both pilots were really encouraging about the benefits to people, to patients, of working their way through the digital CBT program, both in the self-guided and the guided self-help format. The limitations around the evaluations were predominantly the sample sizes. The cohort sizes were small in both pilots. Also, because of the timing around the evaluation period, we weren't able to follow patients up over the longer term, so we're not sure. We don't have evidence around whether those clinical outcome improvements would have been maintained over time. Also, there was some, people who'd been screened in as the program being suitable for them didn't all finish working their way through all of the sessions. Unfortunately, we weren't able to talk to any patients around why that was. So that was a bit of a limit around the understanding that we were able to gain. But that's everything from me. So just next slide, please, and I'll just hand over to Emily for just to finish off.
Yes, I've dropped the links to the different reports, and I have noted a number of questions in the chat about the evaluation, so thank you very much. There may be some that require only a brief response, and we'll aim to do that in this session. Otherwise, we will provide a fuller response as part of the follow-up to this. I do urge you to dive in and have a read of those reports. They both come with executive summaries if you've got limited time to get into the detail, and provided our insight at email address if you'd like to follow up with us direct. So thank you very much for listening, and I'll hand back to Becca.
Thank you guys so much. That's really comprehensive report of what was done over a long period of time. So much appreciated. So if we go on to the next slide, it is my absolute pleasure to invite to the screen Lee and Kat from Dorset, who are going to give us an overview of their experience of the product, the innovation in their patch. Thank you, guys.
Hi everyone, thank you for having us today. So my name's Lee Barker and I'm the Community Service Manager for the Dorset All Age Eating Disorder Service, and by background I'm a mental health nurse. I'm also the Service Manager for the Tier 4 Children's Day Service that we have in Dorset. Kat, did you just want to introduce yourself?
Yeah. Hi everyone, my name's Kat Birtwell. I'm the CBT lead for the Community Eating Disorders Service.
So we prepared some slides for you today, everyone. I'm going to be really honest, and some of them do repeat a little bit of what we've already heard today. So I'm going to do a little bit of freestyling, so I hope you don't mind. And I think one of the things that I'm going to focus on for a little bit is just around, so I guess for myself as a service manager, I spend a lot of time going to things like this, which are really, really helpful. And I think one of the other things the question I then ask myself is, how would that fit in my service and the service that I run? So I guess I'm just going to try and add some of that in to what we're going to be talking about today. So I guess just to give you a quick overview is that I think I attended a meeting that was a Freed meeting, and then I heard about Credo, and then I knew that Credo had an app, and then I think there was a few emails trying to find out about this new thing that we'd heard about, and I guess that's where we were really interested in the app that was being produced and what that would look like. Looking at the service at that point, I guess as an all-age service, and especially with our adult, we had a waiting list. We had a waiting list that was for assessment, and we were trying to think about, are there any things that would be able to help to increase the service capacity? I think some of the challenges that we were having was around sort of the challenges that I imagine people have all had around recruitment, around recruitment of staff that knew around eating disorders, and also those areas that did it there. So I think they're the bits that we were thought about what could we use to try and help us with that. So if we just go on to the next slide, please. So as I said, that we had challenges that was creating waiting times that we felt this would help with. We had high prevalence of binge eating and also bulimia nervosa. We were looking for something that was scalable, and we knew that there was also the evidence around the digital CBTE offer. Next slide, please. I guess we've already looked at some of this, so just about who was involved, so we can go to the next slide. And I guess what we wanted to find out about is if we were to use this intervention and it was the pure self-help version, how would our patients find using this, the feedback that we could get, and about could we think about taking this forward in the future? So to just try and think about how we embedded this into the service at the time, because we had a waiting list, what we actually did is we went through and we reviewed our waiting list. We looked at the referrals that we had, and then we tried to make a decision about, do we think that the person would benefit from having this intervention whilst waiting for an assessment. So when we made that decision to think about would we feel that this person would benefit from it, we gave them a phone call when we tried to get hold of them. If we weren't able to get hold of them on the first phone call, we would then call them again for a second phone call. And then finally, after that, if we couldn't get them on the second call, we would then send them a letter. And within that letter, it was giving them information around an access code for them to be able to access the tool that they would be able to use whilst waiting for an assessment. Sometimes this generated people calling back into the service. So we organised with our admin team that we would have a code for them to reference, and then we would then be able to have a person that they would link to who sort of understood the model and who also understood the app to explain to them that this is what would be happening. So next slide, please. So the intervention was the digital app that they could use via the website or via the by mobile app. As I said, it was for people on the waiting list, and the version that we did was pure self-help. Next slide, please. So the inclusion criteria is that they were over 18. We thought that their primary diagnosis would be binge eating or bulimia nervosa. They're able to use the self-help approach, and they were able to speak. Speak English. The exclusion criteria is significant risk of anorexia, acute mental health risk, and already receiving therapy. When these are the things that we use to guide our decision around who would we be contacting to see if we felt that it was appropriate for them to have an opt-in letter for them to be able to use the app. And I will hand you over to Kat now.
Thank you, Dee. Next slide, please. Excuse me. So this is the data that you've already seen in the section covered by our colleagues at the HAN. So I'll just skip through these next couple of slides. Next slide, please. And as you saw before, there were significant changes in our outcomes. Thank you. Next slide, please. So when we did our qualitative interviews after offering the app to people on the waiting list, we got some feedback from both patients and staff on their experiences of offering this within the service. And I think you saw some of that information in the report already, but people liked having the link to the service. They liked being able to contact us after the treatment. So next slide, please. One of the things that we noticed was that people still wanted contact with our team, although we offered a pure self-help intervention. So some of the people have been waiting for maybe up to a couple of years on our waiting list as a result of the pandemic backlog. So when we reached out to them and offered the app, I think it was quite well received. People felt like they hadn't been forgotten about, that we were still aware of their needs. And they found it quite liberating to be encouraged to have snacks. As we know, some people get stuck in that binge restrict cycle, and being advised to follow a regular eating pattern really gave people structure to kind of practice and feel supported in doing so by the app. Next slide, please. Lee's going to chat to you about the staff experience.
In regards to the staff experience, I think that the amount of input that the staff were aware of was probably slightly reduced, as we only had certain members of the staff that were involved in this. So we had a mental health nurse that would be the person that had made all the phone calls in the initial bit. So they were the one that would contact the patients to see about their if they would be appropriate to use the app, if they'd be interested to use the app. The other thing that we also did is that once someone had completed the app, we would then give them a phone call at the end of the program to see about sort of next steps. Would they like to remain on the waiting list? Would they like to have a period of time before we would take them through to assessment? So generally, the staff feedback from it was that it was very positive. The other thing that I think the other thing that we sort of noticed is that when people would then come to assessment, we noticed that you could tell that the patients that had engaged in it were a lot more able to give us a better understanding of the place that they felt that they were at the moment. So it was quite a positive feedback from them. Next slide, please. So the limitations is that there was a small sample size. There was a self-selecting bias because I guess people were offered about engaging in the app. We had no control group. It was a short-term follow-up, limited diversity, and this was the pure self-help format. Next slide, please. So I guess our takeaways is that we felt that the digital CBT was effective and scalable. It reduced the clinical symptoms and impairment, and it was well received by patients and also staff. I was quite surprised how well it was received by the staff that were interacting with the tool. And we felt that it was useful to be using in our setting. So I'll just hand you over to Kat. Next slide, please.
So after doing the pilot, we made the decision to offer the digital CBTE guided self-help program within the service, because where we found that we really needed capacity in the team was to support people post-assessment, and that's partly in relation to our KPI. So at the moment we have a long wait before assessment. Once people are assessed by the service, they go straight into treatment. So we don't have a delay between assessment and treatment or a waiting list at that point in time in people's journey through the service. So we thought it would be helpful to open up the capacity for people after assessment and to take forward the guided self-help programme. Next slide, please. So this is the structure that we're working with at the moment. After an assessment, if someone has binge eating disorder or bulimia nervosa and they don't present with significant symptoms of depression or risk to self, then we will think about which level of care they might need support with from our team. And in this way, we can kind of best think about how to use the resources that we have. So for people with mild to moderate symptoms, we might look at offering the digital CBT program. And if someone is interested in that but not feeling open to using the technology, we do still use the Overcoming Binge Eating book as an alternative for guided self-help as well. If people are experiencing more moderate levels of purging or perhaps more severe restriction alongside their binge eating, then we'll think about a CBTT intervention. And also, if people are presenting with OSFED and not binge eating, then we will also think about CBTT. And then for people who have significant comorbid health problems, whether physical or mental health, people who are maybe experiencing difficulties with self-harming or complex comorbidities, we would offer CBT-ED with one of our band 6 or 7 practitioners. Guided self-help is delivered by our band 4 support workers, and CBTT is delivered by our band 5 community practitioners. So we can think about the different levels of care when we're supporting people after assessment in our service, and think about flow through the service as well. Next slide, please. Absolutely. If you have any questions, do feel free to link up with us, as well as Lisa, if you have any service specific areas you want to ask us about.
Thank you so much, Lee and Kat. Fantastic overview, and great to see you still embedding it within the service pathway. And we look forward to hearing from you in 6 months or a year's time to see how that's all going. So thank you very much for your time and your involvement in this. We know it's been much appreciated by the innovator and ourselves. Thank you. So next slide, please, Eleanor. And it's my great delight to introduce some fabulous colleagues in Kent and Medway from NALFT, Susie, Natasha and Maddie, who are going to talk to you about their experience of using this product in their eating disorder, all-age eating disorder pathway. Over to you guys.
Thanks, Becca. Good morning, everyone. It's really lovely to be here. My name's Susie, and as you've heard sort of in the previous sort of presentations this morning, the Kent and Medway All-Age Eating Disorder Service, we were really thrilled to be involved in the pilot, and we were evaluating the supported version of digital CBT-E. I'm really delighted to hand over to my colleagues Natasha and Maddie, who can tell you more about our experience of delivering such an innovative and exciting digital eating disorder intervention. Thank you.
Hello, I'm Maddie. Next slide, please. So I just wanted to start by briefly explaining the key differences between the digital CBT in the pathway and our usual guided self-help programme delivered in service. So the digital CBT pathway involves patients completing 12 in-app sessions over the course of 8 to 12 weeks, supported by 15 to 20-minute phone or video supporter calls. These calls can occur sort of twice weekly at the start of treatment, then reduced to weekly as a means of providing flexibility and encouraging early behavioural change. The digital CBT pathway is app programme led as opposed to being therapist led, with sessions released every 3 to 4 days, guiding patients through 3 structured treatment stages. And we found that this promotes accountability and ownership of progress. In contrast, our guided self-help programme in service offers 9 to 12 weekly hour-long sessions, online or face-to-face, where psychoeducation is delivered directly by the practitioner. Both interventions can be delivered by mental health and wellbeing practitioners or assistant psychologists. Relapse prevention is a key component of both treatments. In our guided self-help programme, a therapeutic blueprint is created in our final session. In the digital CBT pathway, this is built into a staying well phase with 3 final sessions spaced out over the course of 4 weeks. And this is a means of mimicking life post-treatment. And this really enables patients to practice their skills and techniques learnt within the app without the weekly support calls. This is to kind of take ownership of their recovery in the long term. Patients also can retain access to the app and its resources for 3 months after completion of treatment, with the optional follow-up sessions to check in on their progress. In summary, we found that offering both options ensures patients can make an informed decision to choose the treatment that best suits their needs, and ensuring that as a service we are maintaining effective person-centred care. So I'm just going to hand you over to Tash now, and the next slide, please.
Thanks, Maddie. I'm just going to briefly talk about some of the benefits and the learning that we found as a service. So this was a new project for our service, which we were really excited to have the opportunity to deliver. And we established some of these key benefits along the way. So cost effectiveness, and by this I mean that it supported reduced clinical contact time. As sessions were slightly shorter, this allowed for caseloads to be managed efficiently, and also some of our HCPs reported reduced administrative time as well. We noticed there was a reduced waiting time for our patients, so our HCPs were able to pick up patients in a more timely manner. And for us in our service, decisions were made at triage and at a mini assessment, and this also supported the reduced wait times for assessments and treatment as well, and also helped fluidity with the waiting list. So as it's been mentioned previously, this was a new and innovative intervention for us, and it was really exciting as a service to be able to offer an alternative to our treatment as usual. And providing patients with a digital offer, but also the fact they could have 24 hours access to the app. There was a real positive response from some of our patients. So they reported liking the flexibility of the approach. And another positive is that patients were able to complete patients who weren't able to complete their treatment for various reasons at the time have actually since returned requesting the digital intervention. So it just indicates to us that this is something that patients were invested and interested in. We also identified some key learning as well via discussions in our supervisions and MDTs. So we found that patients needed to be ready to engage and able to invest their time and effort into the treatment. And we noticed that those who weren't completing the calendar aspect of the app, for example, they were more likely to not complete treatment. We also noticed that we needed to be aware of patients' additional comorbidities, such as low mood, depression, but we also identified that depression wasn't always an indicator of willingness to engage. So as part of our pilot, we reviewed with the Credo team the use of the PHQ-9. So we've written the acceptance criteria. So we started to think about offering digital CBT for the moderate to severe patients that were scoring higher on their PHQ-9. We noticed that just because sometimes they scored higher, it didn't always indicate a lack of motivation. So what we moved towards doing was then discussing each patient that went through the process that had a kind of a high frequency of symptoms on a case-by-case basis, and that included a full clinical presentation to discuss the most appropriate treatment option. Next slide, please.
So I just wanted to share some of the feedback we have received from service users who engage with the app and the pathway, and also to reflect on what I personally enjoyed in my role as a supporter. So on screen, we have included some feedback from our patients, and I'd just like to read through a few now just to highlight the positive and transformative impact of the intervention. So one of the quote reads, "Using the digital CBT calendar helped me to track and remain accountable for my meals and snacks." We found that patients consistently praise the app for their visuals and personalised tools, and especially the calendar and the gold star system for consistent regular eating. Earning stars after maintaining progress for several days served as a clear incentive to support early behavioural change and reduce the frequency of binge eating episodes. The to-do list feature alongside the calendar was also really valued as a practical and empowering reminder of the steps the patients were taking within their recovery. As a supporter, I found it incredibly rewarding to highlight these achievements with patients during the supporter calls to remind them of their progress and the effort behind it and the control that they were regaining. It helped build the confidence, self-esteem and sense of ownership over their recovery. Another piece of feedback we received was as follows. So at first I felt quite negative about myself, wondering if the digital side would work for me or if I'd get anywhere. But with her ongoing prompts, ideas and consistently addressing my concerns, a few weeks in, I started to believe I could actually make a change. So this patient really appreciated the flexibility of the intervention. Many of the users that engaged led quite busy lives, either working full-time or caring for children, and valued being able to choose when and how to engage with the support sessions. So unlike the traditional practitioner-led psychoeducation, which can take up a significant amount of time during weekly sessions, the app provided all the psychoeducational materials up front, and this allowed sessions to be really focused on the patient demonstrating their own understanding of resources, and enabled me to fill in gaps where necessary, or to offer new perspectives and collaboratively problem solve barriers that the patients may have encountered. While some of the patients were initially quite unsure about digital treatment or its effectiveness, they were ultimately impressed by how well the technology worked alongside the offer of supporter sessions. And as a supporter, I found this approach really beneficial because it encouraged patients to take ownership and accountability for their treatment and helping them to become their own therapists throughout that process. So next slide, please.
So in terms of where does this digital pathway fit into our service? So this was a really exciting opportunity to be part of, to be able to deliver an innovative digital pathway to our patients that were diagnosed with binge eating disorder. So moving forward, we see this pathway as an alternative to our already supported guided self-help programs, which we currently deliver. And it's something that more of our team can be and are really keen to be trained in moving forward. So being part of this valuation and patient feedback as well has allowed us to see the importance of having a digital pathway for our patients and for the service, and is something we're really keen to deliver in the future. It supports the NHS 10-year plan in being able to have a digital avenue for treatment in the service. We thought it'd be really nice to just share a quote from one of our team that delivered the intervention, and they said, "Increasing the digital footfall of the service helps with our transformation agenda and highlights this developing area of my role." We would just like to take a moment to thank all the teams that were involved in supporting the delivery of the pilot and the specialist supervision the team have received throughout the process, and it's something the team really valued for the duration of the pilot, and we really look forward to incorporating digital pathway into our service in the near future. Thank you for listening.
Oh, fantastic. Thank you so much, colleagues from Kent and Medway. That was brilliant and great to hear that those voices from staff and patients who've benefited. I think that says it all really, doesn't it? Thank you very much. Last few minutes, we just want to ask Nick to come online, please, and give us an overview of the next steps for Credo and how you can contact them if you're interested, and then to pass over to me, and I'm going to be thanking people and drawing us to a close.
Absolutely. Thanks, everybody, again, for spending some time with us. So Credo Therapies, obviously, we are growing and progressing, particularly focused on building evidence to further support this intervention across the UK and in the NHS. So we'd be excited to hear from other organizations who are interested in working with us. You can reach us through we have a generalized email that's easy to remember. It's hello@credotherapies.com, and that will come to myself and Dr. Debrew. I also dropped my email and Dr. Debrew's email in the chat as well. There were a lot of great questions. I tried to answer a few of them. We will get to and answer all the other questions, and happy to talk about specific use cases or needs that you may have. I think that's it. I'll pass it back.
Thank you very much. And to contact if colleagues want a demo, or they want to, if there's any kind of any information. I know there's a question from somebody in the chat around adolescence, and to reach out to you personally. Thank you very much.
Yeah, absolutely. Thank you.
Thanks, guys. Well, what an hour. Great to see you, or that you could all join us. I want to say a particular thanks to Credo Therapies, for Nick and Lisa for joining us and over the past year. Our colleagues at HIN Wessex, who've done a fantastic, sterling job at their real and rigorous job around real world evaluation, and most importantly to colleagues from Dorset and Kent and Medway at NAUFT. We really appreciate your involvement, and thanks from us to all staff that were involved, that sit behind the scenes, and the patients that worked with us on this. So I would like to say thank you very much. There's a case study there, which is a one-sider, and there's the full evaluations. You can actually click on the screen, I understand, if you want to link up with those. And if you want to contact Credo, you've got the details in the chat. So thank you ever so much, everyone, for taking time out with us today. It's much appreciated.